Our first speaker is Greg Moody, Director of the Ohio Office of Health Transformation. Greg is no stranger to our community and was a keynote speaker here last year when we met in May, and we're very pleased, Greg, to have you back. Governor John Kasich appointed Greg Moody in January of 2011 to lead the Office of Health Transformation. OHT is responsible for advancing Governor Kasich's Medicaid modernization and cost containment priorities, engaging private sector partners to improve overall health system performance, and recommending a permanent health and human services structure for Ohio. Greg worked as a consultant with clients across the country, working to improve Medicaid system performance, and wrote extensively about state health system innovations for the Commonwealth Fund, the National Governors Association, and other foundations. Greg's Ohio experience includes serving as interim director of the Ohio Department of Job and Family Services in 2001, executive assistant for Health and Human Services for Governor Bob Taft between 1999 and 2004, and chief of staff to the dean of the OSU College of Medicine in the late 90s. Interestingly, Greg has been a public service began his public service career as a budget associate for the U.S. House Budget Committee. The budget chairman at the time, Representative John Kasich, asked Greg to study the impact of Medicaid on federal spending, an assignment that, of course, set the course for his public policy career. Please join me once again in welcoming Greg Moody to the podium.
Is that working? There we go. You have a bigger room this year. It's indicative of what's going on here in Southwest Ohio. There is a lot of activity that really sets this part of the country apart in terms of leading health information exchange and the adoption of health information technology. I'm glad to say a little bit about where we are in the state of Ohio. For those of you who were here last year, you're going to see a couple of the slides I used last year again, but with a huge difference. Last year we were talking about what we intended to do, and this year I'm able to talk a little bit about what we've accomplished and where we're going. It's not that different from meaningful use, right? You know, we intend to adopt technology, but it's very different to actually go through the process of practice transformation. Technology is a tool. To what purpose is the question? So some of what I want to talk about is, to what purpose? What are we trying to accomplish? Where do we want to go? We need to go somewhere, right? Because our current system is not functioning as well as it could. We spend more than all but 13 states on our health care in Ohio. But we're not getting better results in terms of quality outcomes. We rank 42nd in terms of outcomes. So there's a disconnect there, right? It's not that we're underpaying, we're paying. What are we getting for that? And it's unsustainable. You know, we're seeing trends in health spending that we can't carry out into the future. So this is a core piece of the problem definition. What is it that we can do to improve the performance of the system to get value out of what we're spending already? Last year, I focused on this area of spending. We spend 52% more on nursing facilities in Ohio than the national average. We're out of alignment. We're over-institutionalized. How on the front end can we care for people in a way that avoids that high-cost setting? It's true also in hospital care. We're 12% above the national average in what we pay for hospital care. Are we getting the value we should expect out of that? It's an open question. It's something I think we need to give attention. When you start looking at some of the data that drives some of that spending, this one's very interesting. Look at this, emergency department utilization. Ohio's in the red, the national average is in the blue. We use our emergency departments about 29% more frequently than the national average. That's not good or bad, it just poses a question, what happened right before that? Or what didn't happen right before that that resulted in an unnecessary emergency department visit? So you can start to see where some of the hot spots are in the system. They tend to be where we don't do what we know works up front, and then we're left with the higher costs later. So what we need to do are find communities that are working on this. This is a good example of the emergency department alerts here in this community that let primary care know when somebody appears at the emergency department or in the hospital to then be able to intervene. Here's another example. What you're looking at here in this is Medicaid. In the blue, these are Medicaid enrollees who do not have a serious mental illness. In the red, Medicaid enrollees with a serious mental illness. These are avoidable hospitalizations. You're twice as likely to end up in the hospital if you have serious mental illness for diabetes, for COPD, for asthma. Another indication that there's something in the system itself that's disconnected. Behavioral health services over here, physical health services over here. How do you get those connected? In the emergency department, are you getting referrals to community behavioral health? In community behavioral health, do you have a direct line into primary care? All of this for the state, this is too complicated to solve every problem, so we really tried to zero in on two basic ideas to define what we could focus on and work on. One is, a very few people are very expensive in the system. In Medicaid, 4% account for more than half of all spending. This is the health system generally, 5% account for half of all health spending. Now, healthcare reform tends to focus on everybody. Increase co-payments, cut optional services. That affects everybody, but it doesn't really save money because most people aren't actually using that many services. Who are these few? Now, some of those few are expensive no matter what we do, right? They have a chronic condition that require a tremendous amount of resources. We're not talking about taking that away from them. But often people end up in that category because something in the system went wrong. Something didn't happen that then led to a condition that could have been avoided and much less costly. So the system itself often is the culprit here, right? We live on the left side of this chart, fragmentation. Everybody's working to get on the right side of the chart. I had a conversation just before I came in here around how in this community relationships are being built to cross over from the left-hand side, from fragmentation to coordination. And you know what? It requires the relationship to overcome the financial incentives, which are to stay fragmented, generate volume, versus financial incentives to cooperate, to provide value. So how do we move from the left to the right? Well, we need tools. Health information technology, health information exchange. To what purpose? Coordination. This is one of the slides I used a year ago. We talked about, wouldn't it be great if we could just clear the slate, and what would it look like for a person? We tend to think in terms of our system. What would be convenient for the hospital, for Medicaid, for my practice? Well, what if you just said, what would be convenient for an individual? An individual shouldn't have to worry about payer source. Medicare does it this way, Medicaid that way, commercial insurance this way. Shouldn't have to worry about setting, acute, long-term care. So how can we start thinking about creating single points of coordination where the benefit is wrapped around the individual in a way where there's coordination? You don't have to do that at one place. You can do that virtually, and the way to do that virtually is through health information technology. Especially those last two bullets, transition seamlessly among settings as needs change. link payment to person-centered performance outcomes. How do we do that? Here's how we're trying to do that in the state of Ohio. I know this is maybe hard to see, but this website down at the bottom is our Office of Health Transformation website. Office of Health Transformation is a group the governor put together recognizing that our system is fragmented. Department of Aging, Drug and Alcohol, Job and Family Services, they're all separate agencies. We brought them all together for strategic planning and budgeting under one Office of Health Transformation. Our initiatives have been organized around modernizing Medicaid. That's what we were working on last year. We had a budget that included some things I'll mention here real quick. Now we're focused on operations, streamlining our health and human services, getting our own house in order, so we can get on to that third area of activity, engaging private sector partners to improve overall health system performance. Line up our programs, get our operational issues in order, so we can be a good partner as government to bring our policies in alignment with the things that are working in the private sector. What are those things? Well, I think a lot of the best practices are here in this community. So how do we bring what we're doing in alignment with what you're doing? Here are a couple examples, single points of coordination in Medicaid. So now remember, a few people who are very expensive. Let's just jump down to the third one, creating health homes for people with mental illness. I'm really excited that in October, we're going to bring online health homes for people with serious mental illness. This is a provision in the Affordable Care Act that provides money for care coordination between behavioral health and primary care. So what we're looking for are geographic areas where behavioral health providers and primary care, patient-centered medical homes are working together. Because we want to say, here's some money to pay for the coordination in that setting. We can define these down to very small geographic areas. So we're on the lookout. Who's ready to take a payment to coordinate between behavioral health and primary care? The fourth bullet, integrate Medicare and Medicaid benefits. This is the biggest thing we're working on. Medicare, Medicaid, totally different incentives, totally disconnected experience for the dual eligibles, the 190,000 Ohioans who are on both Medicare and Medicaid. They account for more than half of all our Medicaid spending. So when you're talking about a small group that's very expensive and where fragmentation works against them, it's an area we need to focus on. We were in Washington, D.C. just a week ago talking to the folks at CMS and feel very good that Ohio is in the front group of states that are working on integrated care delivery systems for dual eligibles. Look at this on our website because it's pointing to the future of where we want to take the Medicaid program with this population. In all of this, we've tried to, government is very incremental, very risk averse. We've tried to push a little faster and further in all of these programmatic areas. We've had some success. The budget last year gave us the authority to act on these things, and now we're rolling a lot of them out. We need to take that same spirit of innovation into our systems. Here's an example, one of our systems, eligibility. We have 150 categories of Medicaid eligibility alone. The computer we use to calculate that is 30 years old. So to get into Medicaid, folks have to physically go down to a county office, sit through a long list of questions, down at question 30, 33, 34, maybe they figure out they're eligible. What if instead we said, forget about the categories. Instead of 150, let's go to 2. What is your income for children? And what is your income if you're an adult? And if you're below a certain income level, you're in the Medicaid program. And then for certain folks, for example, people who need long-term care, maybe we have a couple other tests. We count your assets. 95% of all current Medicaid enrollees could come into the program just by a simple income test. The other thing that's going on, this is the way it looks today. The way you read this chart is over on the left are kids, If you're a child in a family with income up to 200% of poverty, you're in the Medicaid program. You're eligible for the Medicaid program. You can see we have different levels of income requirements depending on who you are, including there's a blank space there. Childless adults are not eligible for Medicaid. In 2014, that's going to change. This is what federal reform will do to the access points to government health insurance. So as a provider, as a system, think about how your payer mix is going to change. Now everybody below 138% of poverty is going to be eligible for Medicaid. We're expecting 1 million additional Medicaid enrollees in January 2014. The expansion groups are those red categories. Childless adults will now be covered. Many of them have severe and persistent mental illness. They don't currently have health coverage. They may be receiving services through behavioral health. And then there's this issue of the health insurance exchange, public subsidies for private insurance up to 400% of poverty. This is going to change the landscape of how and who people access our programs. It's related to a set of interconnected technology operational questions. Modernizing eligibility, sharing information across state and local data systems. We have a lot of information locked up that we can't get to because it's in silos of data. Many of your institutions are the same way. How do we bring that together? How do we integrate claims payment systems, plan for an insurance exchange, and accelerate electronic health information exchange, the subject here? Instead of running these down different tracks, the Office of Health Transformation has brought them together, and we're coordinating these as one set of projects. In the area of health information exchange, there are a few decisions we've made that we're now acting on. One is we're going to elevate statewide HIE policy to the Office of Health Transformation. We're going to establish the role of the state's HIT-HIE coordinator in the Office of Health Transformation. It's a natural point where all of our agencies are together to take on these statewide policy issues. Let me give you one good example, clarifying Ohio's privacy law. You all know that in Ohio, we have this situation where we have privacy law in addition to the federal standard. And confusion around that can create a chilled environment to sharing information electronically. The governor introduced a bill 2 days ago that is going to say that for the purposes of electronic health information exchange, we use the federal HIPAA standard, period. No confusion around other variable privacy law. So that's a good example of you can really only do that at the state level, right? You have to establish something that's a fair playing field statewide to hopefully then accelerate the use of electronic health information. Some other things here, linking meaningful use to practice transformation, extending meaningful use to other providers. What about behavioral health providers? What about long-term care? There are very innovative things going on here in this community about care transitions. The hospitals have an EMR, the nursing home doesn't. So how do we extend the concept of meaningful use to other providers? Ultimately, where we're headed with this is payment reform. How can we leverage the state's purchasing power? And I'm very glad GE is going to talk about from a corporate perspective, how do you think about payment reform? Because we want to come into alignment with that. Think of this. We have 5 health plans in Ohio that cover 83% of all Ohioans. Those are 5 CEOs that the governor could go visit and say, our expectation for what you do to bring about practice transformation through payment reform would look like this. Here's how we feel about a patient-centered medical home. And if we made that visit with GE and P&G and Cardinal Health, it becomes a very powerful way to align incentives. Here's another way to think about it. These are Ohio's top employers in terms of employment: Walmart, Cleveland Clinic, Kroger. What's really interesting is the ones in red are all health systems. Ohio's top employers are health systems. So not just thinking about how to generate volume, they're thinking about how do I control costs for my employees. That's a really interesting intersection, those two hats. How do we provide value for our own folks and extend that to everybody who comes through our door? That's what we want to achieve. So we want to put Medicaid purchasing power on the table with business to get there. These are some of the basic elements. It's what much of this conference is about. How do we standardize performance measurement? How do we publicly report performance? So then we can use those things to reform the healthcare delivery payment system. And not in a one-size-fits-all. Healthcare is a regional marketplace. Where do we see best practices, and how do we rely on those to inform the broader effort? And that's why I'm here, because Southwest Ohio and Cincinnati, the Health Collaborative, Health Bridge, Beacon, this community is already ahead of others in figuring out what those best practices are. There are a lot of these design questions churning around. What's an accountable care organization? What's a patient-centered medical home? We're counting on you to provide the answers we need to say what we need to do to bring Medicaid in alignment with innovation. So I'm very glad to be here to support what you're doing. We have a very aggressive agenda at the state level. I encourage you to take a look at the website. It goes on and on for pages in terms of initiatives we have underway. I think there will be something in there you can see how you connect to it, and I'd love to hear from you how you see that improving overall health system performance for the state of Ohio. Thank you.